Hi everyone, this is Doc Ina and this is my lecture on ectopic pregnancy. To download my lecture deck, please go to my WordPress site Docina Obigaine. Reference for this lecture is Williams Obstetrics, Chapter 19, Ectopic Pregnancy. And this is the outline of my lecture. So following fertilization in fallopian tube transit, the blastocyst normally implants in the endometrial lining of the uterine cavity. So when the blastocyst implants other than the endometrial lining of the uterine cavity, then that is what we call the ectopic pregnancy. Nearly 95% of ectopic pregnancies are implanted in the various segments of the fallopian tube, and this is what we call a tubal pregnancy. And this gives rise to fimbrial, ampullary, isthmic, or interstitial tubal pregnancies. As shown in this picture, the ampulla is the most frequent site, followed by the isthmus. The remaining 5% of non-tubal ectopic pregnancies implant in the ovary, the peritoneal cavity, the cervix, or the prior uterine scar. Occasionally, a multifetal pregnancy is composed of one conceptus with normal uterine implantation coexisting with one implanted ectopically, and this is what we call heterotopic pregnancy. The natural incidence of these heterotopic pregnancies approximates 1 per 30,000 pregnancies. However, because of ART or assisted reproductive technologies, their incidence has increased to about 1 in 7,000 overall. So what are the risk factors for an ectopic pregnancy? First, of course, is a previous tubal pregnancy. For example, a patient who underwent salpingoneostomy for a previous ectopic pregnancy, sterilization, or fertility restoration such as a tubal reanastomosis. Also, risk factor is a previous ectopic pregnancy, and literature states that there is a 10% chance for a second ectopic pregnancy immediately after a first ectopic pregnancy. Other risk factors include salpingitis or a tubal infection, peritubal adhesion secondary to salpingitis, appendicitis, or endometriosis. There's also increased incidence of ectopic pregnancies in assisted reproductive techniques. And finally, salpingitis ismica nodosa, which is a condition in which epithelium-lined verticula extend into a hypertrophied muscularis layer. Now, because the fallopian tube lacks a submucosal layer, the fertilized ovum promptly burrows through the epithelium. Now, the zygote comes to lie near or within the muscularis of the fallopian tube, which is invaded in most cases by rapidly proliferating trophoblasts. So, the embryo or the fetus in an ectopic pregnancy is often absent or stunted. So, what are the outcomes expected in ectopic pregnancies? Ectopic pregnancies may rupture and cause massive hemorrhage. As a rule, if the affected fallopian tube ruptures in the first few weeks of pregnancy, approximately 8 weeks or less, then the ectopic pregnancy is most likely located in the isthmic portion, whereas the ampulla is slightly more distensible. If the fertilized ovum implants within the interstitial portion, then the rupture usually occurs at a later AOG, approximately 10 to 14 weeks AOG. Tubal abortion is another outcome, and this is when the ectopic pregnancy aborts out the distal fallopian tube, and this usually happens in fimbrial and ampullary types of ectopic pregnancies. So when tubal abortion happens, hemorrhage may cease and symptoms eventually disappear. So what is the difference between an acute and a chronic ectopic pregnancy? Acute ectopic pregnancies manifest with high serum beta-HCG levels and rapid growth, therefore leading to an immediate diagnosis. And these types of ectopic pregnancies have higher risk of tubal rupture. On the other hand, in a chronic ectopic pregnancy, abnormal trophoblasts die early, and thus negative or lower static serum beta-HCG levels are found, and usually these types of chronic ectopic pregnancies typically rupture late, and they commonly form a complex pelvic mass. Or sometimes they don't rupture at all. So let's talk about the clinical manifestations of ectopic pregnancies. Usually, ectopic pregnancies present with a triad of delayed menstruation or missed menses, pain, and vaginal bleeding or spotting. If with tubal rupture, the patient manifests with severe lower abdominal and pelvic pain, characterized as sharp stabbing or tearing, plus tenderness on abdominal palpation. Now, there can be symptoms of diaphragmatic irritation characterized by pain in the neck or shoulder, especially on inspiration, and may develop in women with massive hemoperitoneum, usually in cases of ruptured ectopic pregnancy. Now, on internal exam, we may find cervical motion or wriggling tenderness, tender, boggy mass felt on one side of the uterus, fullness in the cul-de-sac, especially in cases of a massive hemoperitoneum or just hemoperitoneum, and uterus may also be slightly enlarged due to hormonal stimulation. In addition to bleeding, women with ectopic tubal pregnancy may pass a decidual cast, such as seen in this picture, which is the entire sloughed endometrium that takes the form of the endometrial cavity. So how do we diagnose ectopic pregnancy? So one of the ways by which we can diagnose ectopic pregnancy is through the beta-human chorionic gonadotropin or the beta-HCG levels. Discriminatory beta-HCG levels, or what we call the discriminatory zone levels, are minimum levels of beta-HCG above which failure to visualize an intrauterine pregnancy indicates that the pregnancy either is not alive or is an ectopic pregnancy. An empty uterus with a serum beta-HCG concentration of at least 1,500 MIU per ml, or what we call the discriminatory zone, is 100% accurate in excluding a live uterine pregnancy. Now, some institutions set their discriminatory zone at 2,000 MIU per ml beta-HCG. If the initial beta-HCG level exceeds the set discriminatory level and no evidence for a uterine pregnancy is seen on transvaginal ultrasound, then the diagnosis is narrowed in most cases to a failed uterine pregnancy, completed abortion, or an ectopic pregnancy. Serum and urine pregnancy tests that use enzyme-linked immunosorbent assay or ELISA for beta-HCG are sensitive to levels of 10 to 20 MIU per ml and are positive in 99% of ectopic pregnancies. For cases where pregnancy test is positive, but transvaginal ultrasound could not detect any intrauterine or extrauterine pregnancy, the term pregnancy of unknown location or PUL is used until additional clinical information allows determination of pregnancy location. Now for PULs, we can do serial beta-HCG level assays to identify patterns that indicate either a growing or a failing uterine pregnancy. Now if beta-HCG level doubles every 48 hours, then we could say that this is a viable intrauterine pregnancy. If failing intrauterine pregnancy, usually the beta-HCG levels decline, and the rates of decline expected approximates 21 to 35%. In pregnancies without these expected rises or falls in the beta-HCG levels, distinction between a non-living intrauterine and ectopic pregnancy may be aided by repeat beta-HCG level evaluation. If there is a suspicion in a stable patient that a PUL could be a normal pregnancy, then just continue expectant management with a serial beta-HCG level assessment to avoid harming an early normal pregnancy. Now, if the patient's history or extruded uterine tissue suggests a completed abortion, then serial beta-HCG levels will drop rapidly. Another way to diagnose is by the use of serum progesterone. A serum progesterone value exceeding 25 nanograms per ml excludes ectopic pregnancy. However, serum progesterone levels that are less than 5 nanograms per ml suggest either a non-living uterine pregnancy or an ectopic pregnancy. Another diagnostic that we can use is transvaginal ultrasound. In ectopic pregnancy, transvaginal ultrasound can detect absence of intrauterine gestational sac or fetal pole, a complex adnexal mass or extrauterine GS with ring of fire pattern. The ring of fire pattern is the placental blood flow within the periphery of the complex adnexal mass. Transvaginal ultrasound can also detect a trilaminar endometrial pattern, a pseudosac or a fluid collection between the endometrial layers and conforms to the cavity shape. A decidual cyst, which is an anechoic area lying within the endometrium but remote from the canal and often at the endometrial myometrial border. And also it can detect hemoperitoneum, especially in cases of ruptured ectopic pregnancy. And as low as 50 ml can be seen in the cul-de-sac using transvaginal ultrasound. Another way to diagnose is through the use of coldocentesis, and this is a simple technique used commonly in the past to identify hemoperitoneum. So we use here a long 18-gauge needle, which is inserted through the posterior vaginal fornix into the recto-uterine cul-de-sac. A failure to aspirate fluid is interpreted only as unsatisfactory entry into the cul-de-sac and does not exclude ectopic pregnancy. Now, fluid containing fragments of old clots or bloody fluid that does not clot is compatible with the diagnosis of hemoperitoneum. If the blood sample clots, it may have been obtained from an adjacent blood vessel or from a briskly bleeding ectopic pregnancy. And so lastly, we can also use laparoscopy. And laparoscopy entails the direct visualization of the fallopian tubes and pelvis and offers a reliable diagnosis in most cases of suspected ectopic pregnancy. So as for the treatment, we have medical and surgical options of treatment. Let's start first with the medical treatment. Patients eligible for medical treatment are as follows. First, a low initial serum beta-HCG level, which is the single best prognostic indicator of successful treatment. A small ectopic pregnancy size, less than 3.5 centimeters, and absent fetal cardiac activity. Eligible patients may be given methotrexate, which is highly effective against rapidly proliferating tissues such as a trophoblast. However, on the other hand, methotrexate is toxic to the bone marrow, the GI mucosa, respiratory epithelium, hepatocytes, and toxicity to bone marrow can be blunted by early administration of leucovorin, which is folinic acid and has activity equivalent to folic acid. The methotrexate is renally excreted and it is a potent teratogen, and methotrexate embryopathy is notable for craniofacial and skeletal abnormalities and fetal growth restriction. So listed here are the medical treatment protocols for methotrexate as treatment for ectopic pregnancy. So we have the single dose and the multi-dose methotrexate treatment protocol. What we usually use for convenience is a single dose methotrexate treatment protocol. So we can see here that we give methotrexate at a dose of 50 milligram per meter squared body surface area, and then we determine the serum beta-HCG levels at days 1, 4, and 7. For the multi-dose methotrexate treatment protocol, we can give up to 4 doses of the methotrexate until serum beta-HCG declines by 15%. And we see here that the dose of methotrexate is around 1 milligram per kilogram at days 1, 3, 5, and 7. As you can see here, we also give leucovorin with methotrexate. Okay, so we determine the serum beta-HCG levels at days 1, 3, 5, and 7. Now, for surgical management, laparoscopy is the preferred surgical treatment for ectopic pregnancy unless, of course, the woman is hemodynamically unstable. Before surgery, future fertility desires of the patient should be discussed. And in those desiring permanent sterilization, the unaffected tube can be ligated concurrently with the salpingectomy for the affected fallopian tube. So for surgical management, we have conservative versus a radical surgery. So for conservative surgery, we have salpingostomy or salpingotomy. So what's the difference? Salpingostomy is when an incision is made over the fallopian tube to evacuate the ectopic pregnancy without suturing it close. Salpingotomy, on the other hand, is incision made over the fallopian tube to evacuate the ectopic pregnancy and suturing it close after evacuation. Actually, this conservative treatment is referred for small unruptured ectopic pregnancies that's usually less than or equal to 2 centimeters. Radical surgery techniques, on the other hand, is usually done through salpingectomy, which is a permanent removal or a section of a fallopian tube, and this is preferred for large and or ruptured ectopic pregnancies. And we have the partial versus a complete salpingectomy. We can also do expectant management, and the criteria for this are the following: tubal ectopic pregnancies only, decreasing serial beta-HCG levels, the diameter of the ectopic mesh should be less than or equal to 3.5 centimeters, and there's no evidence of intra-abdominal bleeding or rupture by transvaginal sonography. The American College of Obstetricians and Gynecologists states that 88% of ectopic pregnancies will resolve spontaneously if the beta-HCG is less than 200 milli-IU per ml. Regardless of location, D-negative women with an ectopic pregnancy who are not sensitized to D antigen should be given IgG anti-D immunoglobulin. Now, in the first trimester of pregnancy, a 50 microgram or a 300 microgram dose is appropriate, whereas a standard 300 microgram dose is used for later gestations. Now, let's discuss some examples of non-tubal ectopic pregnancies. But let's discuss first the interstitial or cornual pregnancy. And this is an ectopic pregnancy that implants within the proximal tubal segment that lies within the muscular uterine wall. Undiagnosed interstitial pregnancies usually rupture following 8 to 16 weeks of amenorrhea, which is later than for more distal tubal ectopic pregnancies due to greater distensibility of the myometrium covering the interstitial fallopian tube segment. And because of the proximity of these pregnancies to the uterine and ovarian arteries, there is a risk of severe hemorrhage. The criteria for the ultrasound diagnosis of interstitial or cornual pregnancy include the following. So first is, of course, a finding of an empty uterus, and then a gestational sac that is seen separate from the endometrium and more than 1 centimeter away from the most lateral edge of the uterine cavity, when there's a thin or less than a 5 millimeter myometrial mantle surrounding the sac, and finally the echogenic line, known as the interstitial line sign, extending from the gestational sac to the endometrial cavity. Surgical management with either cornual resection or coronostomy may be performed via laparotomy or laparoscopy, depending on patient hemodynamic stability and surgeon expertise. Intraoperative intramyometrial vasopressin injection may limit surgical blood loss, and beta-HCG levels should be monitored postoperatively to exclude remnant trophoblast. Cornual resection removes the gestational sac and surrounding cornual myometrium by means of a wedge resection. Alternatively, cornuostomy involves incision of the cornua and suction or instrument extraction for the pregnancy. Next is an abdominal pregnancy, and this is implantation of the ectopic pregnancy in the peritoneal cavity, exclusive of tubal, ovarian, or intraligamentous implantations. Clinically, abnormal fetal positions may be palpated or the cervix is displaced. And the uterine findings for this include oligohydramnios, a fetus is seen separate from the uterus or eccentrically positioned within the pelvis, lack of myometrium between the fetus and the maternal anterior abdominal wall or bladder, and extrauterine placental tissue. An abdominal pregnancy can be life-threatening, of course, and management depends on the gestational age at diagnosis. Most common fetal malformations were limb deficiency and central nervous system anomalies. Most common deformations were facial and or cranial asymmetry and various joint abnormalities. Conservative management also carries a maternal risk for sudden and dangerous hemorrhage. Principal surgical objectives involve delivery of the fetus and careful assessment of placental implantation without provoking hemorrhage. Placental removal may precipitate torrential hemorrhage because the normal hemostatic mechanism of myometrial contraction to constrict hypertrophied blood vessels is lacking. If it's obvious the placenta can be safely removed, or if there is already hemorrhage from its implantation site, then removal begins immediately. When possible, blood vessels supplying the placenta should be ligated first. Some advocate leaving the placenta in place to decrease the chance of immediate life-threatening hemorrhage. If left in the abdominal cavity, the placenta commonly becomes infected with subsequent formation of abscesses, adhesions, intestinal or ureteral obstruction, and wound dehiscence. Now, if the placenta is left, its involution may be monitored using sonography and serum beta-HCG levels. In some cases, and usually depending on its size, placental function rapidly declines, and the placenta is resorbed. However, placental resorption may take years. If the placenta is left in place, post-op methotrexate can be used to hasten involution, but has been reported to cause accelerated placental destruction with accumulation of necrotic tissue and infection with abscess formation. Next is the intraligamentous or broad ligament pregnancy, and this happens when the gestational contents are extruded into a space that is formed between the broad ligament leaves and become an intraligamentous or broad ligament pregnancy. And the classical findings or the clinical findings for this type of ectopic pregnancy and even the management are the same as for abdominal pregnancy. So ovarian pregnancy, this is an ectopic implantation of the fertilized egg in the ovary. And then we have 4 clinical criteria for us to say that this is an ectopic pregnancy. This is what we call Spiegelberg criteria. So first is ipsilateral tube is intact and distinct from the ovary. The ectopic pregnancy occupies the ovary. The ectopic pregnancy is connected by the utero-ovarian ligament to the uterus. And finally, the ovarian tissue can be demonstrated histologically amid the placental tissue. Sonographically, an internal anechoic area is surrounded by a wide echogenic ring, which is in turn surrounded by an ovarian cortex. Ovarian pregnancy may be mistaken as hemorrhagic corpus luteum cyst or a bleeding corpus luteum, and management for ovarian pregnancies has been surgical. Small lesions have been managed by ovarian wedge resection or cystectomy, whereas larger lesions require oophorectomy. Systemic or locally injected methotrexate has been used successfully to treat small unruptured ovarian pregnancies, and beta-HCG levels should be monitored to exclude remnant trophoblast. Next is cervical pregnancy. Then this is defined by the cervical glands that are noted histologically opposite the placental attachment site and by part or all of the placenta. This presents with painless vaginal bleeding, which is reported in 90% of women, and a third of these have massive hemorrhage. As pregnancy progresses, a distended, thin-walled cervix with a partially dilated external os may be evident. Above the cervical mass, a slightly enlarged uterine fundus can be felt, and identification of cervical pregnancy is based on speculum exam, palpation, and transvaginal ultrasound. Transvaginal findings in cervical pregnancy may include number 1, an hourglass uterine shape and ballooned cervical canal. Number 2, a gestational tissue or gestational tissues at the level of the cervix. Number 3, absent intrauterine gestational tissues. And number 4, a portion of the endocervical canal seen intersposed between the gestation and the endometrial canal. Cervical pregnancy may be treated medically or surgically, and in terms of medical treatment, we can use methotrexate, which has become the first-line therapy for stable women with ectopic pregnancy or a cervical pregnancy, and we can also use potassium chloride, and this induces fetal death with intracardiac or intrathoracic injection. For surgical means, we have the suction curettage and the hysterectomy, which may be required with bleeding uncontrolled by conservative methods. Next is CS-scar pregnancy or a CSP, and this describes implantation within the myometrium of a prior cesarean delivery scar. The pathogenesis for CSP has been likened to that for placenta accreta and carries similar risk for serious hemorrhage. And women with CSP usually present early and pain and bleeding are common. However, up to 40% of women are asymptomatic and the diagnosis is made during routine sonographic examination. So for CSP, we have 4 sonographic criteria. First is an empty uterine cavity. Second is an empty cervical canal. Third is an intrauterine mass that is seen in the anterior part of the uterine isthmus. And lastly, number 4, myometrium between the bladder and the gestational sac is absent. So, we can also do some fertility preserving options as management for CSP, and this includes systemic or locally injected methotrexate, either alone or combined with conservative surgery. And surgeries include visually guided suction curettage or transvaginal aspiration, hysteroscopic removal of CSP, or isthmic excision. Hysterectomy is done for patients who do not wish to conserve their uterus. So that's it for our lecture. As a summary, we have discussed the following, such as a classification of ectopic pregnancy, the risk factors for ectopic pregnancy, outcomes, clinical manifestations, diagnosis, management, and we also introduced some non-tubal ectopic pregnancies. Thank you for watching my lecture, and please don't forget to subscribe in my YouTube channel, Ina Irabon, and WordPress site, Tokina Obigaine. Thank you!